ఆట అయితే చెప్తాము. హలో ఎందుకు వస్తుంది? నెక్స్ట్ కొల నోలేస్తారు కదా, నీకు కరెక్ట్ కాదు, నాకు చెవులో కరెక్ట్ ఉండాలి. గుచ్చుకోపోతా ఉంది, మాంసలైన్ లేదు. అరే చెవులో గుచ్చుకోపోతా ఉంది అంటే కూడా అర్థం కాదు మంచికి. పెట్టావా ఆడియో అవునా? పోతుందా వాయిస్ అక్కడ? చెప్పు. గోపాల్ సార్కి ఒక మైక్ ఇవ్వండి. అరే సిటీ స్కాన్ ప్రెజెంటేషన్, సిటీ స్కాన్ పీపీటీ అన్ని రెడీ ఉన్నాయి అక్కడ. वीडियो पे देखना ये ఉంది yellow and different none
Sai, can you got two screens of this?
ये भाई
ఇక్కడ వాళ్ళు ఇచ్చేవారు దాని దూరంగా ఉండాలి
Sai, can we give OT feed, please? Sai, sir wants to see OT feed for some time.
दिखेगा भी नहीं
దగ్గర ఉన్నాడు
रहेगा ठीक है प्रकाश
Good afternoon, everybody, and welcome to this live surgery sessions. I hope you'll enjoy it. At least I like the live surgery every time. And because there are some restrictions, only the full and trainee members of USI can attend this. Associate members are not allowed as per our constitution. That's why you might have seen they are scanning the badges. So please tolerate this sort of stuff and come inside. Now, may I request the chairpersons or the moderators for these operative sessions to come over and take over? Dr. Rajesh Alawat, sir. Dr. Rajesh Alawat, sir is here. Okay. And Dr. Syed Jamal Rizvi. Dr. Jamal is here. Dr. Venkat Gite. And after some time, Dr. Anil Bhasne, Dr. Manohar T, and Dr. Tanuj Paul Bhatia. Sir, all yours now.
Hello, welcome to this live operating session. We have a couple of good surgeries to look at, one live donor nephrectomy and a partial nephrectomy and a TULEP. So I think from Nadia, radical partial donor nephrectomy setup is there. This is partial, okay. Okay. So, yeah. Yeah, but no, I thought, whatever it is, no, let's start the first one. Is somebody there to tell about the case? Hello? Anybody on the other side? Yes.
Sai sir?
Hello?
Sai sir? Can you hear me? Hello?
I think audio link is not working, but anyway. Unless it works, how can we communicate to them to start the case then?
Sure.
Hello?
Hello? Hello? Yeah, this is Rajesh Alawat from the auditorium. Is there somebody to tell about the case?
Yes, sir.
You're
Good evening,
connected to
everybody.
Nadia or AINU?
Greetings from AINU, Hyderabad. This is the first case, 67-year-old female, known case of abdominal TB in 2022, received medication for that. Incidentally found to have left renal tumor. The CT abdominal pelvis showing heterogeneously enhancing exophytic upper polar left renal mass measuring about 4.1 into 3.4 centimeters. Single artery and vein. The renal score is 7P.
Please, can you show the CT again? You cut
Yes.
it short. So the most important part of the CT was not shown. So go down.
Yes, sir.
So that's the tumor. Yeah. And posterior, anterior lip, and going right up to the lip, start of the lip from the upper pole. Good. Thank you.
Yes, sir. Thank you. Over to Dr. Gopal sir and Gauss sir.
Yeah, Dr. Gauss. So what are the things that you think would be important in this, and what are, because it's probably, he can't hear me. He's not hearing. Yeah, so he's doing it laparoscopically. So, because, before he says that, in any such tumor, probably the most important thing is the location and the closeness to the hilum. These are two important things. And it's upper pole, lower polar are easier than upper pole, and anterior are easier than the posterior ones. So in posterior upper pole tumor, one will have to think whether one is able to see all the margins around. Otherwise, we needs to flip the kidney anteriorly across the hilum 180 degree or 180 degree upside down. So they both are possible across the hilum. And can you hear Dr. Gauss?
हाँ, चालू कर दो ताकि वो सवाल पूछे.
Sir, I am audible there? I'm
Yes,
able to
very,
hear.
very much. So what I was asking was, what are the things that you come into your mind, what all you may have to do for this upper posterior pole tumor?
Yes, sir. So basically what we have done is initially now we have mobilized the entire colon, which was all like this. We just mobilized it medially. Our mobilization on the left side goes till the diaphragm, where we start seeing the greater curvature of the stomach. And we see the inferior phrenic vessels coming and supplying as a superior adrenal artery here. And these are the splenic vasculature, splenic artery and vein that we have reflected medially so that we can see the renal hilum and the tumor part very clearly. One more reason for mobilizing so much is the left hand which goes in, if not in vision, can go through the spleen and injure the spleen. That is the reason to mobilize it comfortably medially so that this area can be easily accessible. Once that is done, the hilar control is taken. Once the hilum
get the
is
end of view?
identified as
Okay.
being a single artery, then the rest of the kidney is mobilized. This being a upper posterior tumor on the left side, we need to have a polar flip wherein we can get this part anteriorly towards us so that the resection can be done comfortably.
Exactly. So, that's what I was, so you want to, please go ahead.
Thank you.
Hello, sir. Hello.
Hello?
Yeah, greetings from Nadia, sir. So this is Dr. Abhijit Patil from Nadia. Sir, am I audible?
Very, very much. Very
Okay.
clear, loud and clear.
So, very well. Good evening, everybody. Warm greeting from Murjibai Patel Urological Hospital, Nadia. So this is Abhijit Patil, consultant over here. So we have two surgeries being relayed today. So in one OT, we would be showing one left lap donor nephrectomy, and the second OR we will be relaying a TULEP for BPH. So on the first OT, we have Dr. Arvind Ganpure who would be showing the left lap donor nephrectomy. And now we would have a case to be presented for the left lap donor nephrectomy, followed by opening remarks.
But probably the video which is being transmitted is ready for a TULEP. So please change the video. So you can't do transurethral donor nephrectomy yet.
Abhijit, what we are getting is the TULEP. Oh, okay, now we got it. Yes, sir? The same thing, no.
Same thing, yeah. So get the right connection from Nadia, please, so that we can start.
Hello.
Hello?
So can you see, sir, now the transperitoneal donor nephrectomy?
No, not yet, not yet. I think they are trying to sort it. They will
Yes,
get the
sir.
correct image. What we are getting is the image from
AINU.
So, Mr. Charles, I think we have the PPT and the live relay from here in the Zoom meeting. Can you please showcase over there?
Hello.
Yeah.
42.
So we have a case, 38-year-old male.
yeah. Now we have it.
Now we have, okay.
Okay, sir. So now we are presenting the case. Yes, go ahead, Kunal.
So 38-year-old male, chronic kidney disease, stage 5 hypertension. He had increased complaints of anorexia and giddiness, diagnosed with a creatinine of 8 and started on dialysis. BMI is 25.6. All other examination and investigation is normal limits.
I think we expected details of the donor.
Donor, what you're showing is recipient here.
That's
Okay.
it.
So donor is related as mother to the recipient. It's a mother to son ABO compatible transplant. 57-year-old female, no urological complaints, only a breast surgery and tubal ligation in the past, menopausal, 2 children, BMI of 27.4, examination is within normal limits, all other investigations are normal, uroflowmetry, chest x-ray and USG abdomen within normal limits. So this is the kidney size, right and the left kidney. We are doing a left lap donor nephrectomy. On the left side, there is a single renal artery. No evidence of any stenosis or abnormal dilation is seen. It measures 4.6 mm at its origin. Right side, it is also a single renal artery. However, we will be doing a left lap donor nephrectomy. So these are the relations, renal artery with the renal
You
vein.
have not told us the GFR. Do you do regular DTPs in these patients? I'm sure you do.
So, sir, we don't do regular EGF. So we do EGFRs. We don't do the major GFR using a nuclear scan. And the GFR in this patient is around 92, sir. So now we would like to have opening remarks by Dr. Arvind Ganpure regarding this.
Good morning, good evening, sir.
Hi, Arvind.
Yeah.
Good evening. By the time they are just turning the camera, we would be going transperitoneal. There would be a standard steps which we would be following: reflection of the colon. I will not go posterior to the kidney. I will lift the ureterogonadal packet. Sir, can you see the images, the CT images?
Yes, yes. We
So
saw the
if I-
main image. Yes.
If I concentrate over here, this is the anatomy that we are going to see. We are having a single renal artery, we are having a single renal vein and a circumaortic collar. So after lifting the ureterogonadal packet, I'll lift the ureterogonadal packet at the lower pole, and then I don't want to go into this area of business. I'll go to the upper pole, dissect the adrenal, and then come back and take care of the retroaortic vein. The only good thing in this case is that there is a single artery, and artery is at the lower border of the renal vein.
Just a question, Arvind, how you are sure that the retroaortic one is atretic? Many times the retroaortic one is the main vein, and the anterior communication could be, unless you see it in the cross
So
sections.
I'll answer that question. Actually, I had gone to the CT console and I saw that the caliber is somewhat lesser on the retroaortic part. But yes, I do take your point that maybe we'll have to see it intraoperatively. What are the diameters on both the sides, and then decide which to clamp and give it to the recipient surgeon. Regarding the schematic diagram, I have drawn the schematic diagram over here, and this is what we are going to see over there.
Okay.
By the time, sir, before you go to the other theater, one more important point on the this thing I want to let you know regarding the port placement of camera. bahar nikal ke dikhana. So this is the port placement that we are doing, that we are having the ASIS, umbilicus. This would be the reference point wherein the first port will come inside, one 5 millimeter port. Then we do this calculation that we calculate this distance, which is 16 centimeter. We divide it into 1/3 and 2/3. So at the junction of 1/3, 2/3 goes in the camera port, which we are going to insert the camera. So in this way, we'll be exactly in front of the hilum. That's what we suppose.
Thank you, Dr.
Yes, sir.
Ganpati.
Thank you, sir. Thank you.
Hello. So, sir, we also have, so do we have Dr. Tanuj Paul Bhatia over there?
Yeah, Tanuj, come here, please come.
Yeah. So we have the second OT where we'll be relaying the other case of TULEP.
Please come.
Hello, Dr. Tanuj Bhatia.
Yeah, he's here.
Yeah, okay. So we would like to have a case presentation for this TULEP case, and maybe have Kunal to present that case for TULEP. Can you see the presentation?
Yeah, please go ahead.
Okay.
So 65-year-old male complaining of voiding LUTS since 1 year, refractory to alpha blockers, known case of diabetes mellitus since 10 years, controlled, external genitalia has a left hydrocele, digital rectal examination is within normal limits, serum PSA is 2.93, other investigations are normal, USG bilateral upper tracts are normal, normal size kidneys, prostate 80 cc with the 15 mm median lobe. This is the USG picture suggestive of a median lobe intending the bladder base. Uroflowmetry, max flow rate is 6 ml per second, voided volume is 174 ml and keeping a PVR of 40 cc. This is the transrectal ultrasonography done, which is suggestive of a 58.4 cc prostate.
58 gram, not 80.
So, okay, warm greetings again to the moderators of this session, Dr. Tanuj Bhatia, Dr. Manohar, and Dr. Anil Vashne. We have Dr. Ketan Vartak who will be operating on this case. Can we have Dr. Ketan Vartak online for his opening remarks for this TULEP case? Over to you, Dr. Ketan Vartak.
Just a minute, sir. Kevin, can you pin the other image, please? Can you pin the other image on the right side big screen? And can the mic be unmuted from the other theater? It is on mute.
Yeah, now we have the image. Dr. Ketan Vartak, you can go ahead.
And can this side be muted, please? Yes, Dr. Vartak.
Can you hear me?
Yeah, we are able to hear you.
Yeah.
Good
evening, everybody.
Good evening.
So I'll just show you the instrument and the settings.
Yeah.
So this is the IPG thulium fiber laser machine, and the energy is 1 and the frequency is 40, and the hemostasis energy is 0.3 with the frequency of 67. So I'll be doing, I've done the cystoscopy in the meantime when everything was getting arranged. So this is a verumontanum. There's a large median lobe here, but fortunately it is divided. So there is a cleavage in between.
Can we have the internal
Right.
image, please? Yes.
The right orifice is here,
Yeah.
and the left orifice is here. Okay, and the rest bladder is normal. The rest is everything is okay. So I'll be doing a bilobar technique TULEP. So my whole idea is to go into this cleavage, make a 6 o'clock incision till here, take an inverted U and do a bilobar. All right.
Yeah.
So
Ketan, I am Dr. Anil Varshne. For the benefit of audience, suppose somebody is absolutely going to begin to learn this technique, would you suggest median lobe only enucleation, or would you tell them to do bilobar or en block?
yeah, but because here in this cleavage is not very deep, so still I'll recommend 2 lobar. But if this was deeper enough, like the right side, then probably 3 lobar will be easier.
What energy settings you said? 1 joule and 40 hertz.
It is easiest to enucleate.
You said 1 joule and 40 hertz. So this is the energy which you always use, or do you vary these permutation and combinations?
We can vary depending on the tissue and the energy.
So one of the problem with the lower energy is more charring, and TFL per se there is a bit more charring. So why is it that you prefer this setting only in a 60 watt laser?
We'll just start incision and just see how it is going.
Sure.
All right. So I'll just start here. So this is 6 o'clock. Can you reduce the light? Pilot light? I'll just reduce the pilot light a little bit. Enough. Yeah.
It's still too bright, I think, the pilot light. Is it comfortable for you, sir?
Pilot light? You can make it 0 because it is hampering the vision. So the thulium fiber laser can act in 2 ways. One is this pulse energy which can dissect like a TULEP, and second is the continuous wave, which is like a holmium, like a thulium yag. So right now what I am doing is the pulse wave energy. So if you want less charring and the holmium-like effect, then this pulse wave energy is better. If you want a thulium yag-like effect, then
I think the partial is at a critical stage. Can we move to the other OR, please?
Yes, please. Yes.
Hello, and Dr. Gauss?
Sir, where would you like to go to?
Partial nephrectomy.
AINU, please. AINU, please.
Hello.
Can we pin the other image? Kevin, can you pin the other image from Mujibhai Patel?
Can you connect audio to AINU, please?
Hello. Okay. So AINU bigger. AINU bigger, please.
Hello.
Hello.
What is your opinion? Audible, please.
I think we are getting 2 audios.
Hello.
Is my audio?
Yeah, which place are we connected to? Who is listening?
Sir, now it's AINU, sir.
Okay. So Dr. Gauss, we have been following you. Good job. So, you have dissected the whole kidney posteriorly around you have separated the adrenal, the upper pole, and you are doing the hilum, and you were starting to mark the tumor with the ultrasound when you switched to the hilum. So
exactly. So this is the solitary renal artery that I could see.
Yes.
There's nothing there in the upper part of the window that I've created.
Yes.
We always have this double window technique wherein we create a window above and below the hilum. But this being a posteriorly located upper polar tumor, we had to mobilize the entire kidney.
Yeah.
If it would have been an anterior tumor here, I would have stopped with creating these 2 windows and gone ahead with the clamping and resection.
Yeah.
But the posterior tumor, we had to mobilize the entire thing, and that is the edge of the tumor that we are able to see now.
Yeah.
Luckily, this patient is not that fatty and there's no thick sticky fat all around. We could mobilize it quite quickly. And this is the tumor. Now I'll start doing an ultrasound to know as to which angle to enter into this parenchyma to enucleate it or to do a resection of the tumor.
Good.
Any questions, any comments from the hall, please?
No, just wanted to see you scoring so that, we can ask questions at that time if there are any.
Sure, sir. Can I have the
Yeah,
ultrasound?
any question from the audience?
No, sir, this is not a question. This is a request that we should see the lab donor continuously on this screen, at least in PIP mode.
Oh, yes.
Sir, now we are watching 3 theaters running.
Yeah.
So you will have all the 3 images at all times.
Actually, what you are showing is the AINU is duplicate.
We are seeing.
Kevin?
So on the right side, you should show both the procedures.
Both the MPUH.
Can we have
Pin
that?
both the MPUH on the right side. Kevin?
Image visible there?
No, it's a double AINU image. AINU has somehow, I think they have Bob.
Is
They
there
have,
the ultrasound image there?
there, you have done something, boss. How is it possible that mine is duplicate?
And the topic is approach to management of agricultural cooperative. Welcome,
I
Mr.
think now it's fine.
Seen there?
Yeah.
Sir, now you have all the 3, sir?
Yes, thank you so much. Now it's
Welcome, sir.
no, it cannot be.
1.5 and 1.
So there are 2 screens. So you can only have, we can't have 3 screens.
Are you able to see the ultrasound image from AINU, please?
We can't see, we can see the ultrasound image, yes.
Yeah. So we put a Doppler, we could see the vascularity all around the tumor. And this is the edge where the tumor starts. Remove the Doppler.
We can't see it very clearly, but we'll have to believe you.
Are you able to see the demarcation, sir?
Sir, sorry. AINU, can they interchange the ultrasound and the laparoscopy image, please? Can they interchange, make the ultrasound bigger? Thank you.
With the endo image.
Yeah, you can see the demarcation of the tumor clearly here.
Yes, sir. It's a quite big tumor, almost 4 centimeters, reaching
good capsule. So
renal sinus and the calyces in the upper pole. So this is the laparoscopic endo ultrasound that we are using. We are not using that drop-in probe which we use in robotics. This is the endo ultrasound of laparoscopy. So we can have a good control. We can flex it all around on whatever direction we want and go in any part of the kidney and visualize the borders where we can start resecting.
So
Yeah,
I
is the
see
image better now?
Yeah, we can see the image. Can you start marking so that we can?
Sure. Can I have the scissors with monopolar?
Which port are you using for putting in the ultrasound? Do you have a extra port on the right side?
Can somebody show the external view of the ports?
Because
Okay. So this is the standard port placement that.
is it going through the assistant port or there is no assistant port here.
Are you able to see the external picture now?
No, sir.
Oh, I think the cameraman is just pushing.
Yeah.
Yes, sir.
Yeah, sir. So which port were you using for the ultrasound probe?
Yeah. So this is the standard port placement for any partial nephrectomy or a radical nephrectomy. This is what we have. A right-handed 10 mm port, a camera 10 mm port, and a left-hand 5 mm port. So these are the 3 ports we regularly have for any radical.
Which port were you using for the ultrasound?
Port in partial nephrectomy is for the assistant to do the suction.
Okay, right.
And support the kidney when it is totally mobilized.
That's what I was wanting to tell. Then,
Since you will have using it for the ultrasound now.
No, but how would you mark it then? You need to have right-sided ultrasound as well as both the ports, both the ultrasound image.
We do an ultrasound, we get a visual clue of the area where we are putting the probe, and that point is marked again with, exchanging it with the scissors.
Okay, you will exchange it, right?
Yes. The other option is you can have it in the assistant port.
Yes,
and do an ultrasound simultaneously and do it, but I don't prefer doing a ultrasound, I mean, simultaneously and then marking, rather do an
then
ultrasound.
that's what I was
my
thinking, that it's
field
always
area
better.
And then having a visual clue and then do the marking.
So it's always better if one can do the, see and mark at the same time. So
Agreed,
now
sir.
he'll have to remember the visual image.
Yes,
of
we will
what
have
he
to
saw.
have the visual image in the mind and mark it according to some landmark that we had seen on an ultrasound on the kidney.
Any question from the floor? We can go to the other hall.
Right, Kevin, can
Can
you
you
make
go to the donor?
Mujibhai Patel bigger? And yes, Dr. Yes, Dr. Ganpule, you're on.
Move to Dr. Arvind Ganpule's theatre.
Yeah, Dr. Ganpule, you're on.
Yes, so
Dr. Arvind?
in the meantime, when you are gone, I was listening to the conversation. We lifted up the ureterogonadal packet.
Okay.
They always say that the water flows below the bridge. So this is the bridge and this is the water. Once we lift it up, the next landmark is we want to see the anterior wall of the renal vein. So this is the anterior branch of the circumaortic collar. And as Alawat sir was saying that this might be the broader one, I'm not very sure, but there is a possibility that this might be the bigger one.
Yeah, that looks like very bigger.
Looks like a big
And
one.
it's very long also.
And if you can see here, that is the artery.
Yeah.
That is the artery behind. So, but now we'll follow the way we always do it. I'll go to the upper pole. I'd like to see where the adrenal vein is and then come back.
Okay.
Any questions, comments, sir?
No, nothing.
So you
Doing
preserve
very
the
well.
golden triangle there.
Yeah, so we would like to see, once you separate the adrenal, the hilum, and where artery, we can see the arterial pulsations there.
Yes, the
between
artery
two.
is seen. In fact, I'll show you the route, Hana.
That is the adrenal what is coming down from?
No, no, that is the renal vein, the anterior branch of the anterior, what I must say, limb
Communication of the
renal
vein. Yes.
And this is the artery.
Okay.
Yeah.
That is the artery over there.
Yes.
Exactly as the picture that we saw. Now only some amount of dissection is remaining, so I'll keep on doing it.
Yeah, please do it.
Please
Yeah,
go ahead.
can we move to the other OR in MPUH, where the prostate is going
With the
on?
TFL.
Yeah, Ketan, can you hear us?
Can they? Yes.
What
he's
I've done is
unmuted.
6 o'clock
this-
incision I have completed.
Yeah.
You can see the capsule everywhere. Here is the verumontanum. I have taken the inverted U incision here on both the sides. And these are small nodules which are coming in my way. I had made a plane here, but I could go here, which is a better plane. And I could just enucleate this slope separately.
So you always do mechanical enucleation at this level.
This is just a small nodule, so it doesn't require any, just
So
back
for
over,
such nodules, you will have to go behind the nodules.
Yeah, it is just got separated already.
So that means we are not still behind the nodules, means anatomical plane is extending below.
No, this was the limit. So
Yeah.
there is a small nodule here. This nodule
You
is
have
already
cut
off.
through one of the nodules, is it?
Plane here.
Yeah.
Yeah, there's one more nodule is here,
Yeah.
which is also in the plane.
So that is very important. While you are enucleating, sometimes the prostates could be nodular and bossylated. And one may have in the beginning, can create multiple planes. So see the vigilance with which Ketan is enucleating. These lobes, the nodules, they tend to make you go in between the nodules. And then you are lost. So therefore, very important that you maintain the correct plane all through. Now
The
question.
important
Yeah.
thing is, this is the verumontanum. I have enucleated it till 3 o'clock. Okay. I have done at 12 o'clock.
Yeah, show us at this point, because this is the most important point where you can create pressure, and mechanical push will cause stress incontinence. So how will you prevent stress incontinence? That is important.
So, can you see my hand movement
Yes, yes.
in TP?
No,
So
we
I have
can't
held my
see.
telescope
Yes, now we can
upside
see.
down.
Hmm.
All right. I am keeping my left hand steady at verumontanum. This is the verumontanum here. Okay. So at the verumontanum, I'll just lift it up. So this is my end of anterior commissure. So I'll make a sharp incision here, so that I'm not going distal to this area.
So I think that's a very important message that you must mark the sphincter and go 5 millimeter proximal to the sphincter. That would prevent any kind of pressure or mechanical force on the sphincter. Now this mark is
see
important.
here,
Yes, now it is
capsule.
very clear. You
But
have
this is
you
not
have
the capsule,
got
this is the substance of the tissue.
yes.
Okay, so I have not gone into the capsule anteriorly. I have gone till the capsule posteriorly. I'll just join these two so that I'm in the single plane on both the sides, anteriorly as well as posteriorly.
Can we move on to the partial nephrectomy at AINU? It's important step is going on.
But, okay, over to AINU, please.
Yeah.
Try this.
Dr. Gauss, you are
Can we mute? I have muted. Can we unmute at AINU, please? Make AINU bigger, please, Kevin.
Dr. Gauss.
Important inflammatory organ because.
Yes, sir. You're back, sir. AINU, you're on again.
Mechanical friction and friction promote infection.
Are we connected?
And I already spoken.
Yes, sir.
Yeah,
you are.
Dr. Gauss, you are on. Dr. Manohar
Your
and Dr.
volume
Raja
is a
are
little
here.
low.
Uh-huh.
Oxidative stress is common.
Can somebody help with the audio, please?
Are you able to hear me now?
All trying.
Yeah, Gauss, you are on.
That's it to go on for a while. I mentioned about metformin.
You can see the differential perfusion of the kidney, sir.
Double sound is coming.
Dr. Gauss, Anand here, just tell them to adjust the volume a bit of your mic.
Weight loss, I mentioned. State. Weight loss must stay.
Audible now better? Are you able
Dr.
to?
Manohar?
Yeah, yeah,
Dr.
yeah.
Manohar, are you able to hear him well?
Yeah, now.
Yeah, this is the differential perfusion that we are having in the tumor versus the kidney.
Correct.
We applied two bulldogs here. We have given an ICG, IV, and then we have switched on the infrared light source so that we can see this differential perfusion.
Don't you think that if you kept some tissue at the summit of the tumor, you would have held it and, which usually we do it, there what you want is holding it with the left hand. If you just kept behind some fatty tissue there.
Yeah, but this is a very thin lady, so I couldn't find any perinephric fat around.
Oh, okay.
Hold this, please.
Do you have a fluorescence also in your system there?
Yeah, this is a 4K system of Olympus with ICG, with infrared and yellow enhancement. Yellow enhancement generally would be helpful while doing a resection of an AML. Yellow enhancement for a minute. This is the yellow enhancement where you can see all the yellow fat very clearly with a contrast.
Okay.
Now, what we have utilized here is the indocyanine green. We give it IV, and if suppose the kidney has got multiple vessels and you have clamped one of the vessels, you can have a perfusion from the other vessels, or you can also see a differential perfusion between the tumor and the renal parenchyma. Watch this. So I'm trying to get into the plane between the parenchyma and the pseudocapsule of the tumor. At one point, we'll translucently see the pseudocapsule of the tumor, and that is what we will go ahead with. Keep a section here and keep it there only.
I think that's a very important point, that you can only mark the periphery with the ultrasound, or only the periphery. The positivity of the tumors, whenever the margin positivity always occurs at the base. So you have to go along you should have to see well, or you have to go along the curvature, finding the capsule, pseudocapsule.
At least at one place, yeah.
And secondly, that it's very important to do capsulotomy before you go underneath. Otherwise, you will never be able to lift the tumor. So
absolutely, sir. That is what the most toughest structure, and unless we inside the capsule, will not be able to enter into the soft.
Yes, it will not be possible to lift it. So capsulotomy all around, or as you go, keep on incising the capsule at the periphery is important step.
At the same time, while we are resecting, we should also be aware of the areas where we could find some vessel, so that they need to be included when we are doing a inner rhinorrhaphy. Don't talk so much.
I think that's a good progress Dr. Gauss is making.
I think we have reached the pseudocapsule area at one point, and I'm just marching all along. Suction कर दी चालू.
That's a normal parenchyma here.
Yes, sir.
That's a normal cortex. So,
Yes.
but he'll soon reach the capsule here also, because you know, he has found pseudocapsule at one
Here I
point.
think we have reached the
Yes.
pseudocapsule of the tumor, and that is where my scissors turns. It was all in the while this side. Now it turns the other side so that I can get onto the other end of it. Suction, please.
That's a, you know, yeah. So now he's incising on the side. So as he keeps incising on the side, the tumor will, it will be possible to lift the tumor.
Getting some
And as one would notice that he had not clamped the vein. So,
Yes.
you know, that's why you would see some sinus bleed intermittently as the suction is going on. If you are getting into sinus and too much of sinus bleed is bothering, you can put a clamp on the vein as well.
Yes, sir. We can have
Yes,
some
that is a
pressure with
capsule.
your left hand. That itself will
That is a
stop it.
capsule, you got it now.
Beautiful plane now.
The deeper tissue.
A very important role done by Dr. Rajesh now is lifting the tumor so that I
Yeah.
can have a counter traction and go on dissecting. That is the PCS problem. Lift it here. Lift it here. Yeah. That is the projection of the tumor, I believe. Pull it here, please. Yeah. Pull it here, yeah.
Needs to go around from the sides now, actually. And the other side, yes.
PCS that got open.
Very well done, Dr. Gauss. So what was the clamp, what is the time so far?
What is the warm ischemia time till now? 10 minutes, sir.
Good, wonderful job, very wonderful job. So once he starts the rhinography, we'll have more questions. Can we go to the other side?
Yeah, can go to the donor.
Donor nephrectomy now. Dr. Ganpule?
Oh, can they unmute Dr. Ganpule, please?
Can you make it big screen? Can you make
Hello.
that big screen, donor?
Can you hear me, sir?
Yes, sir, we can.
Yeah.
Yes, so we went to the upper pole because I did not want any problem while coming here. So I
Okay.
clipped the adrenal vein. I made sure that some amount of stump is remaining on the renal vein side of the adrenal vein. I went over here, I could see very well the adrenal gland. I made sure that I don't go very close to the kidney. If there is some branch or something, although it is not there, I know it. Then, as they say, that gonadal and the psoas are our friends. So I saw the psoas, and from there I went up to the posterior abdominal wall. A little bit is remaining, but that's fine. After that, some amount of tissue remaining on just superior to the vein was taken care of, and now only the part remaining is the part, this particular tissue in between this vein and the artery. I need to see the ostium of the artery. Any questions, sir?
Go ahead.
I think, please go ahead. So I think donor nephrectomy is one of the surgeries that probably all of you have been doing. And during the upper pole, I think it's very important, the point that Dr. Ganpule just made out, that, you know, if you remain close to the adrenal, then you are unlikely to damage any supply to the upper poles, because some small branches can be going to the upper pole and if you are away from the adrenal. So just be very close to adrenal when separating the adrenal, leaving some tissue on the kidney side rather than going flush to the kidney, which you do normally do in other kind of nephrectomy. Yes, can we go to the
The prostate, sir?
Yep. Yeah, we can go to the prostate for a while.
Can we unmute on the other side, the prostate side? Thank you.
Ketan, are we back with you?
Yeah, yes, sir.
So,
So this is my 6 o'clock incision. Okay. And this is the lateral incision. Through the cleavage I have gone.
So this lobe you have practically enucleated.
Yeah, practically enucleated. And this is the.
Where is the attachment left now?
Yeah, only the bladder neck attachment is left.
So this is nearly 3 o'clock attachment.
Yeah, 4 o'clock. 4 to
3
5,
or 4 o'clock, now you are doing the dissection.
So this is 6 o'clock, I am joining to it.
So this step is simple because once you have defined from above and once
Yes,
you have
sir.
defined from below, you are left
Yes.
with a mushroom which is attached only to 3 o'clock. And this very important, you should observe what Ketan is doing. This is a sweeping motion. You see, he is joining from one V to the other V. So already if you have defined the plane of enucleation, then it is continuously you are making a sweeping motion and joining from one end to the other. So this is relatively simple if you keep both the ends in sight. So I think that's very beautifully demonstrated.
And one should be aware of where your uritic orifice is.
Yes.
Because then in case you are firing inside the bladder neck, then it is likely that it will get injured.
Another thing which is very important that everybody says that when you use TULEP, it is lot of charring. What I would like to tell you all is that if you are in the right plane, there is hardly any charring. So
Yes, sir.
one has to understand the depth of correct plane. Because holmium it is easy to be on the plane, but in thulium it requires a little bit of learning to stay in the correct plane.
Ketan sir?
So, yes, we are listening to you. Ketan, just if you have any final words before you enucleate this lobe.
There is some fogging in your camera.
Yeah,
sir,
yeah, there is some fogging. I
Yeah.
just clean it.
Sir, if you use 1.5 joules and 40 hertz, will it be a faster enucleation?
It is already done to 1.5.
Okay, that's
Yeah, I think 1.5, 40 is faster.
Yeah.
So you can finish it faster. So we go to the partial nephrectomy now.
Yeah, can we go to the AINU, please? Dr. Gauss, are we with you? Dr. Gauss? So Dr. Gauss has done the inner rhinography using a barbed suture. So he probably, he did not encounter pelvic calyceal system, or you can take pelvic calyceal system separately. I like to take it separately, close it with a PDS or some other suture, and not take the barbed suture on the pelvic calyceal system.
Can you connect audio to Dr. Gauss, please?
Dr. Gauss?
Yeah. I have done the inner rhinography now. Sir.
Yes, we can see that beautifully done in earlier. Did you feel that you encountered pelvic calyceal system anywhere?
I think while resection at one point, I have seen.
Yes. During resection, we saw that.
Up into a calyx.
Yes.
But suturing, I think, got included in one of the bites.
Mm-hmm. Okay. Yes.
After rhinography is done, I would now start with the outer rhinography.
Okay.
With the V-lock again.
So
and this time we have a clip attached to its end, so that we start from outside. The previous inner rhinography we start from inside itself, so we don't have a clip outside.
So you would complete both the layers before you release the clamp. So you don't believe in early declamping.
Yes, sir. Traditionally we do this. Probably take 3-4 minutes more. Rather, will be more secure and more.
I think it's not saving the time. It's probably, you know, if you take the second, both the layers together, then sometimes you may miss a bleeder, arterial bleeder, which you have compressed at that time, and later on it can become a AV fistula. So probably, you know, you can see much better if you.
When the field is dry.
But both the ways are good. I like early declamping now. So, you know, early on the career, we always did everything together and before we finished it. But we saw higher number of AV fistulae earlier on than we see now, only because, you know, we do early declamping now. So first layer of rhinography, declamp, and if you see any bleeder, it bleeds a bit, but it's never so much of bleeding that you can't take it, control it at that time. So that gives you that advantage that you don't miss any, compress any bigger bleed. Any comment from?
Point taken, sir, but I would prefer a dry field for me to take a proper corticomedullary bite and have a clear field while I am taking the second layer also.
What is the size of the needle is this? Is 26 mm or 36 mm?
What do you say?
Size of the needle.
Needle.
Size of the needle. Show that picture.
This is 26. If you have a 36, you can have a 1/5 bite coming across the both cortex.
Sir, I would prefer to take a cortical bite, come in the junction of the middle and the cortex, and then take a separate bite rather than taking a full thickness bite from this end to this end, sir.
Yeah, there are various types of rhinography. They do it between
It will give a better coaptation of this edges, sir.
Yeah, usually the inner rhinography, they take the little 1/3 of the lower 1/3 of the cortex and medulla that seals the whole medullary, and you can get away with only the inner rhinography itself if you take lower 1/3 of the cortex and medullary stitch.
There is another point that, you know, these are the tumors from in the periphery where you have the cortex on both sides and you can do outer rhinography. But when you do parahilar tumors, you have only a U or only 3 sides or only 2 sides of a cortex. And then it may not be possible to do a second layer of rhinography. So, you know, those are the places.
In that case, we can have a running rhinography all around, sir, rather than getting the edges together.
Yeah, so you have single lip on which you have to do a mattress suturing.
Yes. That one way. The other way, what Malik sir follows is we put in a perinephric fat in between, so that the dead space is obliterated, and then do the outer rhinography.
Beautifully done, Dr. Gauss. Very well done.
Thank you, sir.
Let's move on to the donor nephrectomy now.
Audio for donor nephrectomy,
Audio from
please,
donor.
Dr. Gan. Ganpule sir, can you hear us?
Yes, we can hear you. Am I audible?
Yeah, you are audible.
Yes, so now this is the last part that is remaining. I'll just let you know what we did.
I think both the veins look similar diameter.
Yeah.
Yeah, I think you have to save both of them. Would you want to expose the...
Rectangle. Sorry?
What is your plan now? Both look similar.
My plan is to give a retrieval incision now. I have gone up to the ostium over here. I can see the ostium over here, the renal ostium.
I think you should clear it out to see the aorta.
Yeah, so this is the aorta there. That is the aorta. Right angle then.
So would you like to preserve both of them, or you would like to cut one of those?
As of now, I will preserve
So
both
this is
of them.
again 12 o'clock.
Once I give the retrieval incision,
I'll continue. No?
I
Don't
will
wait,
cut
no?
this one first. This
So you
one
want-
first.
so you want
And then
to-
I will go for this one.
So you're planning for an
this
early
is
retrieval
until
incision
midnight.
before you further dissect.
Now I'll start going deep.
So you're telling that you would like to do early retrieval incision and start dissecting in case of any...
Still the tissue.
Yes.
Once I go ahead of Vero, now I'll start dipping.
Both.
Now we go deeper.
Yeah, this is the capsule now almost. Already you know the capsule plane here. Yeah, this is the capsule.
Shall we go to the prostate? Anand, can you move on to the prostate? Dr.
Ketan sir, can you hear us?
Yes, sir. So what I've done is I've lifted this lobe also.
Yes,
Okay. This part from say 6 o'clock to 8 o'clock is little mechanical. So this is the everything is lifted now. This is the lobe, and here if you see this tissue I have left behind, you can see the capsule here. This is not the capsule. This is a tissue here, which I have purposefully left for the continuous purpose.
Okay.
And once I'm away from verumontanum, I've started dipping, and this is the capsule again. So now I have a capsule here, and all around till 12 o'clock. So 12 o'clock, once I inside this part, I will join this capsular area. So this will avoid the stress as well as through incontinence totally. Because like TURP only we are leaving that much tissue.
One question, Dr. Ketan. I am Dr. Manohar here. In my very short experience of doing this TFL fiber, we did few cases. We found that postoperative dysuria was very, very troublesome during postoperative period as compared to HOLEP. What's your experience in that?
No, I don't think so, because see, if you do keep on doing vaporization a lot, then there's a lot of charred tissue there. So if you see this, if you see the floor, you don't see any charring tissue at all.
No, in general, I'm not talking about the other chart tissues. They are not.
Yeah.
When we use this laser and we do it because we hardly see any blood vessels coming under the picture, and the coagulation is so deep, and the effect on the tissue is actually it looks much deeper than as compared to holmium. And but we found, I mean, it was the main reason and area where we didn't wanted to continue with that because of the dysuria was real troublesome as compared to holmium.
No, in my experience, normally within 24 hours, less than 24 hours, you remove the catheter.
Okay.
And even if you remove the catheter within say 18 hours or 20 hours, the dysuria part is not there at all. The severe frequency urgency incontinence is there for a few days. Otherwise, irritative symptoms, I don't think there's a lot.
Actually, it's a little unfair. You have 3 HOLEP surgeons in the panel.
So you're only one.
So, yeah, and I think sir has sir was doing thulium YAG earlier and now TFL.
Yes, yes. But even if you compare thulium YAG with TFL, almost it is similar, and even the characters wise as well as the result wise, it is similar. YAG is much faster and it is far better and superior in vaporization as well as hemostasis. But otherwise, practically speaking, it has hardly any difference.
Ketan, what you are saying is good for many patients, but what Manohar has said, it has to be a complete, clean anatomical enucleation when you want that patient has to be, because this is one question which has not been answered very well, because every patient is different. Sometimes you leave lot of tissue and nothing happens, but sometimes you have done excellent dissection and still patient has some symptoms. So therefore, it requires a randomized controlled study which has not yet come up between TULEP and HOLEP, which will require long-term evaluation for this thing, to answer this question.
So up till now, whatever studies are there, it is not shown any superiority of any laser versus
but they have
any other
calculated mostly the voiding parameters, and this is something not have been highlighted. But even to me, I have found the results of holmium enucleation far superior. So maybe that it translates into the randomized controlled trials and we get the answer to this question.
That is because theoretically speaking, holmium laser is a dissecting laser, and you keep on dissecting in between the plane, whereas these lasers are cutting lasers, so you don't tend to cut a little bit. So
No,
for
it's
example,
not
that
only
area
the
that I
question
showed
of cutting,
anteriorly,
it is
that
the
have cut
depth.
across the lobes. So it is by definition it cannot be a true enucleation because you are leaving behind some tissue. So probably that's why by definition enucleation is by only by holmium or mechanical.
Now we move on to the donor nephrectomy. Anand?
Partial also is ready.
Yes, yes.
Sir, now I have given the retrieval incision, and I'm on the process of retrieving the kidney. I'll go as below as possible for the gonadal as well as the ureter. So I will hold the ureter and skeletonize the gonadal. So like so, I'll push the tissue down and go as below as possible. My plan is that the anterior vein appears to be a smaller vein, and the artery, I would like to dissect it a bit below towards the ostium. So I'll first take the anterior vein. Yeah, then.
Sir, you have one more partial?
Right. So I'll take a single clip on the ureter.
So you are ready for retrieval now.
Yeah, so the graft is well perfused, good amount of output.
That's good.
So Manohar, I was just saying that I would take the anterior vein first, because as we had discussed that we think that both the veins are of same caliber, but the anterior vein appears to be slightly smaller. And as you just mentioned during the discussion that some amount of arterial dissection is required near the hilum, not the hilum, till the aorta. So once I take the anterior vein, I'll get good amount of space to dissect if something is remaining over there.
Yeah, anyway, you've done the early retrieval incision. You could have.
So let's come back to you once you are at the hilum again, while you are dissecting the posterior part. Let's go back to the AINU theater, please. Is there something, some points that Dr. Ghosh wants to make? Hello? Connect it to AINU, please, Dr. Gauss.
Yes, sir, you are audible. Am
Yeah.
I audible there?
Yes, yes, please.
Just wanted to show this cut surface of the resected.
Yes.
You're able to see the area of the pseudocapsule at this point, at this point, at this point, and a few areas where the parenchyma is only attached. The rest of the tumor is translucently seen. We haven't breached the tumor anywhere.
Yeah.
Minimal, yes.
Classic enuclear resection.
Yes, sir. We have completed within 23 minutes of warm ischemia time, both resection and suturing.
Good
This
job.
is our policy here to always watch the resected tumor, this surface, so that we are not missing anything anywhere.
Yeah, excellent job.
And we have also confirmed the reperfusion of the kidney after declamping by giving the ICG and then switching on the IR again.
You did that?
And I also want to mention about this new launch of this Olympus instrument that they have introduced now. This is a special grip forceps with only the tip, which has got a tremendous grip. You can do a fine grasp of any structure while you're, especially when you're doing a hilar dissection. And this is a teardrop shaped Maryland, which can be used for dissection all around the artery. So this is a blunt instrument with a good grasp, and this is again a very nice grasper. Now this is again an ICG image showing a very good perfusion, no leak of any blood from the area of resection. Any comments from there, sir?
No, thank you very much, Dr. Gauss. Very well done.
Are you doing the nephropexy?
Yes, sir. We'll be fixing this kidney to the lateral aspect
Okay.
completely. We have got one more case. We'll try to transmit it till the session lasts.
So
one more partial.
let's go back. Let's go to the donor, please. Donor.
Dr. Arvind, we are with you.
Dr. Ganpule, we are with you.
Yes, so now what had happened that I had not applied the clip on the vein side, and the other vein was draining, the artery was not taken. I wanted to dissect the artery, and that's the reason why I did this thing. Otherwise, this can never be done. I know that thing. So I wanted to go up to the ostium. Right angle dena? Right angle dena?
You're quite close to the ostium.
Yes, sir.
Yeah, so there are people who want to see the aorta, like probably Dr. Manohar wanted to.
Yeah, that's the reason
But
why I wanted to do
I don't
this,
want
but-
to see the aorta because I have,
No, in this case, especially I was taking because there's a,
first half centimeter of the renal artery belongs to donor. So if you have two branches, make them pantaloon, do extra work, but never risk. I would never risk the donor. So I would have enough half a centimeter, minimum half a centimeter, where you can put two clear clips and a one metal clip bit distal to them. So minimum 3 clips in the donor I would like to keep, and a minimum 2 millimeter of a stump beyond that. So because I have seen people, these these artery coming up and bursting into the in ORs. So these things can happen. So my teaching always has been the first half a centimeter of artery, never bargain of that, but never want that.
so in this case, what I was arguing is that because of the vein was small, to get into the extra length of the vein, if you see the margin of the artery, you can see in front of the aorta, you can easily
Yeah,
clip
I
it.
think he has done the same thing, that he has left good stump, safe stump on the artery. So because even if the artery clips, you have to have an arterial stump which you can hold. If you don't have enough stump to hold, you have aorta. So you always leave a little bit of a stump on the artery, renal artery, when you put the clamp. Anything, Dr. Ganpule? Any pearls from your side?
So now I've completely detached the kidney posteriorly, nikalna. And now this is the tongue of tissue. I saw once Dr. Alawat, he used to put in an gauze inside and open up the peritoneum. But somehow I tried it once or twice. I'm not that facile as sir. So I don't open the peritoneum. I keep it open. I keep it till the point I can see the blue of the peritoneum. And once the kidney is completely separated like so, my assistant will start opening the peritoneum. Now it is there. I will just hold my, hold this thing, hold. And then I'm going to open the peritoneum and then remove the ports and then retract the kidney. Just show the surface.
Yeah, we can see the surface now.
Can see.
Chhod them. Chodo. So I caught hold of the Maryland and then brought the kidney out.
Good.
Well done, Dr. Ganpule.
Thank you, sir.
A lot of.
We would like to see the graft once you have cleaned up everything after perfusion, so that we can see what would you do with the two arteries there.
Okay, I will show you on the bench. In the next 10 minutes, we'll be showing you. Sir.
Okay. Right.
You said that you don't want to put a gas piece inside, right?
What I had seen is that sir used to keep a gauze pad over here, put in Alice over here, and then he used to open the peritoneum. But here I had just kept the peritoneum, the shiny bluish of the peritoneum just there, and then I incised the peritoneum once the kidney was free.
Okay.
That's the point I wanted to make.
Another point is that we used to keep the bed, we try to put our hand and put the gas piece at the mop inside, and while removing it, we used to see the thread of the
using or spurter, we'll be able to see it.
We put a mop or gas piece onto the bed, and then when you were removing it, one of the threads of the gas piece you stuck to the wet clip, and we have seen that wet clips are getting
yes. So whenever you are lifting up the gauze, it should be lifted up and brought out. It should not be shoved out in this way.
So can we move to the prostate theater, please?
Yeah.
MPUH.
नहीं अभी पहले बंद कर देना.
So this is the bladder neck area, and here is the verumontanum. The enucleation is beyond verumontanum on both sides, more on the right side, patient's right side, and everything looks okay. Coming to again charring effect, there is hardly any charring you can see anywhere. Some parts where hemostasis is done, some parts where it was held for a longer time. Rest the whole fossa looks okay. And if you see here again, if you see this is verumontanum. If you see here, this is all tissue. This is all tissue. And this is a tissue, this is a capsule. So this part of the tissue is left behind for the continuous purpose from almost 3 o'clock to 9 o'clock. So this is a capsule and this is a tissue which is left. So there is no chance that he'll have persistent stress incontinence or a true incontinence. So once hemostasis is proper and my outflow is very, very clear, so I think we should move on to the morcellation.
Yeah, I think Ketan has done a good job.
Thank you, sir.
Thank you very much. And this point which you are highlighting at this moment, that leaving an apical pad of tissue anteriorly goes a long way in safeguarding continence. So that message has to be loud and clear. And only thing which I would like to say is that many times in Indian patients, we have chronic prostatitis. So this combination of mechanical and vaporization is not as easily feasible with the thulium fiber laser. And with holmium, you can do that clean enucleation even if there is prostatitis and prostatic calculi. So that there is a potential which we see that you are leaving lot of tissue hanging from here and there, but still enucleation has been achieved because you have utilized lot of mechanical combination with vaporization. So good job, thank you.
Enucleation is done only at the paraverumontanum.
Yeah, so now we would like to come back to morcellation, and before that I am told that the OT at AINU is ready for second case of partial nephrectomy. Is it?
Can you connect to AINU, please?
So,
audio to AINU.
While we arrange for morcellation, we go to the, kindly present this case from AINU.
Second case.
We can hear you, please go ahead.
Yeah, please, we can hear you.
Second case, 57-year-old male is a known hypertensive. He underwent robotic radical prostatectomy for localized carcinoma prostate on December 2025. His current PSA is 0.02. Pre-op imaging showed incidental finding of right renal tumor. This is a CT image showing enhanced well-defined soft lesion in posterior aspect of the right kidney.
I don't think so.
This is a CT video. It is a single renal artery and vein. Renal score is 4P. Plan is laparoscopic.
Can you mute the MPUH-OT? We are getting...
Yeah, can we move to MPUH-OT, please? Donor bed preparation, the bench.
Hello. Hello.
Hello. Yes, Dr. Ganpuli.
So we have got the graft on the bench side, and as you can see that we are dissected both the veins. This is one vein. So that is one vein, and the other vein, and this is the other vein, and this is the gonadal, and this is the gonadal. So once we lift it up, the whole thing will come out, and we'll also show you the artery. This is the artery over here. So that also we have got a good length of the artery. We'll just give some do some polishing at the end of the edges.
Good job. So what do you plan to do for the vein? Anastomose both of them?
We'll be ligating one of them, sir. The anterior vein appears to be a smaller vein.
Okay, so you will ligate the anterior vein and use the retroaortic
It is the similar assessment that you did after seeing the CT scan. The anterior one is actually the smaller one, and the retroaortic one is a broader one.
Right.
Sir, I just wanted to make a few points that here, before I sign off, is that most important thing here is that we, during the retrieval, I slightly underestimated the diameter of the anterior vein. So generally, if it is a small vein, we don't apply a clip on the graft side. So here, actually, I did not apply a clip on the graft side and it started bleeding. So that is one take-home message that I would like to give, that if the caliber is same on the CT, then probably it's a good idea, because the blood is pumping from the artery. So a significant amount of outflow is still there.
Yeah, actually, this was because the kidney would get congested otherwise if it was the only vein.
So can I ask a question
Yeah,
for
please,
Dr. Arvind
please.
Venkule?
Most welcome.
The artery was seen very clearly between the window between the two veins. So in this case, why not clip the artery first and then handle the veins? That would have reduced the bleeding, and handling of the vein could have been relatively easier.
Actually, the reason was the same, that the point was raised that actually I have not dissected up to the renal ostium, renal artery ostium. So because the ostium was lying behind the anterior artery, so I thought that once the retrieval incision is given, the gonadal is taken care of, the ureter is secured. After that, I'll clip the anterior vein so that I can go up to the ostium of the renal artery. Otherwise, if that was not the case, then I would have taken the artery first.
Okay.
The vein first.
I think the point that he wants to make is, or anybody would like to imagine, is that whenever you have multiple veins and the kidney is fixed medially, so you can't lift the lower pole very well to go to where the artery of origin or renal artery origin is. So there was a lot of tissue around the artery, and probably he thought that if he has a single vein attached, then he would be able to clear it.
So the point actually is that he did an early relaxing incision, retrieval incision, so that, in the case of eventuality, such case, that is actually the good point here is that when you're having a multiple vessels, multiple veins, you tend to have complications of tear. So better to have an early retrieval incision. In case of eventuality, you can immediately clip the artery and retrieve it. So that's also a good point what he did. So overall, I think it was a good show, Dr. Arvind. Congratulations.
Thank you very much.
Congratulations, Dr. Gauss, Dr. Ganpul.
So we go on to the AINU theatre.
Yeah, we can go to AINU theatre.
Or we go to
the morcellation. We can do them.
Yeah, morcellation.
Discuss the morcellation while he's dissecting.
Morcellation. Can we go to the MPH theatre, endo theatre?
Chetan, are we with you?
Yeah.
Are you ready with the morcellation?
Morcellator, it is not creating that negative pressure.
Okay.
That's why I'm waiting.
Which morcellation you are using?
Everything is ready, but I'm just waiting.
No, go ahead. We are looking at
Yes.
for morcellation, because they have another case of partial nephrectomy.
Still
Go
it's
ahead.
going on. Dr. Ketan, what is the morcellation you are using? Which one?
This is the IPG morcellator.
Which
Black
one?
Piranha.
Piranha.
Intercardia. Black Piranha. Not the Piranha. Piranha wolf name.
Yeah, wolf one.
Black Piranha from Intercardia.
This is to and fro or a rotatory?
This is both oscillation as well as rotatory, but I am doing oscillation right now.
Oscillation.
I don't find any advantage in rotatory.
This is from IPG.
Intercardia.
Intercardia. Can you show the?
Yeah, I just show you the.
Yeah, we are showing, sir.
Yeah, to the information that now a lot of morcellators are coming, like disposable morcellators are coming from Taiwan, and they are actually the weight of about 150 to 200 grams. And it has got a suction, it has got a morcellation, which we can do about 10 cases. And I think there is going to be a lot of exciting days ahead with the morcellators, with a lot of people coming with the disposable morcellators with oscillatory blades. I have used few of them and they work really well.
Yes. Even the handheld morcellators are there, but I find these with the processor better than those.
Yeah, there are few people even invented the marcelloscope also, the disposable marcelloscope. Everything is comes in a disposable marcelloscope and receptoscope and marcellator. This is a marcellator. In fact, it's a battery operated. You can carry it. It's just about 200 grams. You need not have to, because as compared to
it doesn't have a processor. It is only a handheld small thing.
Yeah, the earlier, the luminous, the Wasakat was weighing around 1.5 kg. You have to hold it and you have to do it. So actually it is marcellator field, this is exciting. And also there is a new one come from Piranha. They have got a new blade. They have made the diameter a little bigger and it works really well now, because that it catches even the small nodules. It won't form that bumpy nodules. The mothballs effect is not there. So the new version of Piranha is also good. And the other advantage is that Piranha, you need not have to do a Piranha, but you can take out the Piranha suction You can directly
Yeah.
connect it to the suction, and you can
Normal
adjust
suction,
suction in your OT theater. That also can be worked out very cheaper as compared to the piranha effect.
And the main advantage nowadays is it can go through the 22 French morphoscope.
Correct,
And the
correct.
same morphometer can be used with 22 French.
Yeah,
So
all
this
the
is a great
morcellators, yes.
advantage nowadays.
Most of the morcellator will go into
Yeah.
mini, even it goes into 18 French, 20 French, 22
Yes,
French.
yes.
So that's advantage. But only thing is the 18 French, 20 French, what happens when you put a morcellator, the flow will be less and the vision is
Yes.
not as great as 22 or 24 French. I
Yes,
think
yes.
if you are
Because the size is
dealing
small.
with a morcellator, if you have some little of bleeding and if the prostate is very huge, if you want
Yes.
taking more time for the morcellation, I think it's better to use the 24 French
Yeah.
just to have a
Yeah.
good vision and good irrigation.
Yeah, yeah. But in those cases, then what I do is I switch on from 22 to 26 French.
Yeah.
And then morpholate for the larger prostates.
26,
In case
okay.
that is so.
I think there's 24, 26. 26 is a trade-off between 26 and 22. I think 24, my workhorse is the 24 French.
Yeah, yeah.
So we move on to the partial nephrectomy from AINU.
Yes, yes.
10 minutes, 10 minutes. We go to the AINU and who is operating the AINU? Dr. Ghosh? I thought Mallikarjun has gone there.
Dr. Gauss, the first question. The prostatectomy was done in, can you hear me, Dr. Gauss?
Please, go ahead, sir.
Dr. Gauss?
Yes, sir.
The prostatectomy was done in December 25. What was the hurry of operating on a 1.8 centimeter tumor?
Exactly. The patient is paranoid as to harbor one more dreaded tumor than the prostate cancer. Am I audible, sir?
Yeah.
Yeah, we are hearing you, Ghosh.
The patient's daughter is a doctor. When the CA prostate was diagnosed, we very clearly told it's an SRM, you need to be on an observation. But they are so paranoid of getting it removed because the daughter knows that the renal tumor is more dangerous malignancy to harbor rather than a prostate cancer. So they are very paranoid, they want to get it as soon as possible. So that is the reason we are doing. One more reason is got a Usicon.
The patient preference.
Okay, so the point is well taken that, it is SRM and it could have been very well washed because let him recover very well. That would have been my advice, to recover from this surgery well, continence and everything before he gets another trauma.
Dr. Gauss, are you planning for a non-clamp, this half-clamp technique for this?
Yeah, he's absolutely continent with the CA prostate surgery, sir. After RRP, it's been almost a month now. He's doing very well, and he's a patient from outstation. So that's one of the other reasons they want to get it done and go back.
That may be another reason for them to get it done.
Yes, sir.
No, I was asking.
Ultrasound is a very small tumor, as you said,
Yeah.
SRM, and the ultrasound image, I think you can see, it looks slightly bigger on an ultrasound, probably because of the magnification, but
Would you like to do a half-clamp for this?
on the right side, rather, being a centrally placed tumor, rather I would do both artery and venous clamp. But as you said, we'll just do an arterial clamp and then plan to resect it, sir.
So you can dissect and keep
No,
it.
his question was, okay, would you try and attempt an off clamp?
Off clamp, is it? Okay. No, sir.
Okay.
I wouldn't
Okay.
Got it.
venture doing an off clamp for a small tumor, that too when the surgery was not very well indicated. No heroic thing, his creatinine is normal, he's doing very well after the primary surgery. So rather do a proper job without doing an off clamp.
Point well taken.
So this is again a very thickly stuck fat all around the kidney. This is a sticky fat. I could dissect out a bit of.
We could see that quality of fat was not very good. Sometimes it's so sticky.
Yeah, this is a very sticky fat that we have got all around, sir. Somehow I could dissect out, and this is the area of kept it attached so that I can manipulate it. Otherwise, I don't have anything to handle it.
Question to Dr. Rajesh Alawat. Have you used the Veriset?
Yeah, Extensively.
And extensively, and what's your, I mean, what is the
So
size
for,
criteria and what is the ideal indication?
nothing. If you don't see the sinus or if you have done the first layer, for the second layer, it can work very well. As I said that, I do early declamping. And if once the major blood is taken care of, bleeders are taken care of, for the cortical one, I would not do outer rhinography, which would constrict and take away a little bit of parenchyma. So probably it is a bit of again, another nephron sparing attempt from my
So
side.
on table, you would like to assess
Yes.
whether you don't pre-plan it for a very
No,
site.
we keep it ready all the
Okay,
time.
on table, you see that, if there is,
So only the cortical part left. So for the second layer, I'll just put the varicet and glue.
yeah. So you're clamping?
The first time I used varicet was in a live surgery demonstration.
Okay.
So I didn't know what to expect from it, but it worked very well. And since that time, I use it regularly. But obviously, you have to watch, you have to be ready, do no major arterial bleeds. So, but for the cortical bleeding, it works pretty well. So the clamp has been put.
First case, you put 2 bulldogs, now you're putting 1. Is there any?
There is very short stump, sir. There is an antibranching also in this case. That's one reason. Second reason is quite posterior to the renal vein. I couldn't get a much bigger window there.
Okay.
And that's the third reason is this being a small tumor. I don't want to dissect more around the artery and then cause a spasm or anything. So
We have a good bulldogs. I mean, is it absolutely required to do to put two? You also
that was
put
one of the
Dr.
suggestion from the audience there to put 2 clamps. That's the reason. Otherwise, routinely we do only one.
Yeah, I also used to do regularly 1. Now I think there's a lot of people using 2. What is your experience, Dr. Rajesh?
In transplants, I put 2 on the iliac artery. Depends on the size of the vessel. Sometimes, inadvertently, one of the clamps can slip off. Yes, please.
The truth is, 3 years down the lane, the scanline will not be so effective. You start using the second one because it starts bleeding. As the time wear and tear, the effective.
So what is the time duration you feel that?
I don't know how many times you used it before.
300 case if you
So
use it.
which clamps are you talking about?
In fact,
Scanlan.
in my experience, Scanlan, I have got a Scanlan. In my experience, what happens is the one state clamp, what I was using it after 3 years or 4 years, I started realizing that it doesn't compress completely. Then I started using the second clamp. The current clamp, what we are using, that's one is enough. The state clamp requires one more clamp to be kept. So it is your wear and tear in the bulldog which makes you to use the second clamp or not.
Yeah, the springs may become loose over a
The
period.
take-home message is that, if you have a new version, use one. If you use plenty of times, then better not to take chance, put one above the other. That's what the experts are here
And if
to.
you have enough space, always put 2.
Space constraint. But now we also have to see that we're putting a bulldog in a injury to the artery.
Oh, yes.
I think we always underrun that. There's definitely some amount of injury to the artery will be there, especially in the elderly. If they are more than 60, 70 years, there's some amount of calcification. Are you going to damage that intima?
Absolutely. I learned from Rajesh, which he told me 10 years ago, when he said, why don't you do an ultrasound next day morning to understand whether there is a perfusion there. But anyway, now we are seeing the perfusion, but it can still happen that I had one case in the last 10 years where I didn't see perfusion next day.
One with me. And I learned it from Indy, in the Dr. Gill. He said that he has lost one kidney. You put the clamps off, think that everything is hunky-dory, kidney is not bleeding, and it's that the whole of the kidney is ischemic. So it can happen when you have atherosclerotic artery and you put clamps on that. So
this could have been possible off clamp, as you said.
He's got a wonderful plane of dissection just on the, he's enucleating it actually. So
now you can do off clamp and do it now. Yeah, I mean, when you got the cleavage, there's the time also you can release it. I mean, there's no hard and fast rule here. You just have to reduce it. I would have done this. I mean, when you got the capsule, then remove the arterial clamp and then proceed.
Yes, sir. Agreed.
But for a discussion's sake, in a normal renal functions, in a good kidneys on both the sides, If you are able to finish a job in 20 minutes clamping time, are we justified in trying to do off clamp and getting into problem?
No, that, not at all.
I would completely agree with you.
That's
Hey, you and I, we do agree with that, but then it's a practice to go ahead with, I mean, this is a very small tumor, especially again, what we are talking, if the patient is more than 60 years, I think diabetic patient, hypertensive, more than 60 years, I think we have a case for that.
But I think the kind of plane that he's getting, and we are seeing
going to
now,
finish it faster.
it would not have been faster.
Yeah,
with the-
100%.
even
Yes,
with
yes.
the off clamp. So, and he would not have saved extra nephrons.
Hold it here. Tuck.
Dr. Ghosh, you have 5 minutes more. Not for you to surgery, but we may go out. You
Yeah,
can take your time.
We may leave you. Please take your time. So,
Thank you, sir. Thanks for
That's a very good enuclear resection you are doing it. We are all appreciating, we are enjoying your surgery.
Thank you, Manoj, sir.
And
Very
your
good.
boss
Very
is
good
here,
demonstration.
he is also enjoying. He is enjoying more than himself doing it.
Sir, thank you.
So there is some issue with the marcellator. I think if there is any final comments, I think
We
it's,
can talk to him.
yeah, we can go to the final 5 minutes for the MPH theater for the Dr. Ketan Vartak. Yeah, please.
Tumor is done. Wonderful.
Yeah.
Manoj?
Yes. Who is speaking? Dr. Gauss or Dr. Vartak? Ketan?
Yeah, Ketan.
Yeah. Is there any issue with the marcellator there?
Yeah, still there. It is not getting sucked in. The tissue
Suction?
is not getting sucked in.
Suction is not happening. Okay, this is
Yeah,
the
yeah,
problem. Yeah.
yeah.
So the
So,
marcellation is actually very, very important. It's also got a lot of learning curve, and it is technically very demanding procedure.
Yeah.
And if the
So if
suction
I had
is,
known it before, I would
yeah.
have left the lobe hanging at the bladder neck and resected it. But since they are free lobes.
No, whatever you were waiting is absolutely right. If the technology is not right.
We'll just call it a day and they will
Yeah,
change the
sure.
model
You take your time. Make sure that proper suction is there, because we don't want any untoward reactions and complications.
Is this the
No,
right case
I've
for?
done at least 8 to 10 times up till now, and it is absolutely safe to do that.
Is this the right
In
case
fact,
for
these
very
necrose
set?
tissues, they can be morcellated in 5 minutes
Rajesh,
after a couple of days.
is this the right
So
case
because
for very
the
set?
tissue becomes very soft, and for larger prostate also you can finish in 5 to 10 minutes.
Sir, in these newer oscillators, sometimes these connections, if they are not done properly, the suction connections,
Yeah, these
maybe
are
someone can just
engineers
change
from the
these
company itself,
those and see,
and
and
they
then
have
it
been
will
after it
start
for half
working.
an hour. So
Yeah.
last try. I'll give a last try. You can see it. I am firing at it, but nothing is happening. It is not getting sucked in.
It's something to do with the connection
I
of the
think,
tubing, sir.
I think, it would have been much better to put a clip and come in from the outside in, and then do the inner rhinography, rather than having this clip at the bottom, because the first knot, it's never tight. So, anything you wanted to make a point, Dr. Mallikarjun?
Will be the right case for a very set, what we were discussing today?
Yeah, that's what
yes.
is.
That'll be the
Small surface area in
Small
the
surface
base.
area.
just
Small.
cortex,
Yeah.
put in a very set, press for a minute, and it's done.
Dr. Ghosh, you have a very set there with you.
Suction को लगा के कुछ नहीं हो सकता ना? Directly suction.
You have, I think we have to ask you. You have the setup there, Dr. Mallikarjun?
Yeah, that's very
Then
set.
I
They have
think-
shown it. Actually, in fact, that's the reason why I'm asking why are not they using it.
Okay, probably he is asking your permission. Probably you can call him and tell him.
He's showing it, showing the pack. But now actually sutures were not needed. I think we'll close this session here.
Congratulations,
At the-
Dr. Gauss. It's an excellent surgery.
Congratulations
to Dr. Arvind and Dr. Ketan Vartak.
Thank you very much for the session, and all the audience here who have till the last moment been with us. Thank you very much.
Thank you.
Back. meeting అయిపోయిందా లైట్ ఆఫ్ Sir, okay. If they're watching, we'll put a very set. Also, let them see that.